so I'm going to speak in English only. So the purpose is we'll be reviewing the primary echelon lymphatic drainage patterns for head and neck tumors and which tumors would drain to these levels 3 and 4. We will be reviewing the anatomic borders for levels 3 and 4 and some of the relevant organs at risk in the vicinity and our strategies to contour them. So levels 3 and 4, as many may have seen this type of diagram, is basically lives right here along the internal jugular chain and informally is known as the middle and lower jugular lymph nodes. And also part of 4 is also known as the medial supraclavicular lymph nodes. When we look at why levels 3 and 4 are important and why it's important to know how to contour them, it's important to look at some very important reference here, which I have listed, which defines lymph node target volumes for treating head and neck cancers. And so if you see them, for example, oral cavity cancers, cover 3 and 4. Oropharyngeal cancers, hypopharyngeal cancers, laryngeal cancers, even nasal and paranasal sinus tumors, you may consider treating levels 3 and 4. So it's just one of those things that I just wanted to emphasize is why we're reviewing these target volumes is frequently levels 3 and 4 are going to be part of your lymph node CTV. So let's start with level 3, otherwise known as the middle jugular lymph nodes. Is my speed okay in speaking for the Spanish interpretation?
I think it's going perfect, Dr. Patel. Thank you.
Okay, perfect. Thank you. So level 3 middle jugular lymph nodes, these receive lymphatics from levels 2 and 5, retropharyngeal, pretracheal, and recurrent laryngeal. So as I had mentioned earlier, frequently when we are treating tumors of the oral cavity, nasopharynx, oropharynx, hypopharynx, larynx, and thyroid, we are considering contouring levels 3 and 4. So let's first review just the details of what are the actual borders for level 3. So superiorly, it is the caudal edge of the body of the hyoid bone. Inferior border is a caudal edge of the cricoid cartilage. Anteriorly is the anterior edge of the sternocleidomastoid muscle and posterior third of the thyrohyoid muscle. And I'll be illustrating this. Posterior is a posterior edge of the sternocleidomastoid muscle. Lateral is the deep medial surface of the sternocleidomastoid muscle. Now remember, these borders are referring to the intact neck that has not been surgically disrupted. And I'm going to touch on that and how that lateral border can change. Medial border is the medial edge of the common carotid and the scalenus muscles. Okay. So, does anyone want to take a guess? What is the correct order of cartilages from superior to inferior? Is it A, B, or C? I don't think we have this one as a poll.
Do we have a poll, right? Let me 1 second.
I don't think we have a poll for this one, but if someone wants to put in the chat.
Okay, perfect.
Any guess? Anyone have a guess?
Adelante todos, por favor, para seleccionar cuál creen que es el orden correcto de superior a inferior de los cartilages. Dr. Patel, I'm seeing a lot of B.
Okay.
B, like,
all right.
I think
yes. Correct.
Same B.
Correct. B. So many have probably seen a sagittal 0 gram in the hyoid, thyroid cartilage, and cricoid cartilage. So let's see if we, so now if we're looking at the anterior border, this is the anterior edge of the sternocleidomastoid muscle. And this is the thyrohyoid muscle, right? So that's where I said the posterior third. So this space is important, and this is the anterior border. Let's see, I don't know if we can remove this little drawing here, but
Yes, I will work on that.
okay, no worries. So then lateral border is the medial edge of the sternocleidoid muscle. Okay, this is right here. Posterior border, posterior edge of the sternocleidomastoid muscle. Medial border, okay, is the medial edge of the common carotid right here, as well as the scalenus muscles here, okay? These muscles. So if we draw it, that's what it kind of comes up. Some people call this, and we'll touch on this, you know, sometimes it looks like there's like a thumb sticking up here. So let's start with our first Zoom poll. Which of the following is a correct way to contour the elective level 3 lymph nodes without any level 5 coverage? A, B, C, or D?
1 second, I will launch the poll. Es la forma C o D. I think I will give like 20 more seconds. We're having almost the 50% of participants. Okay, I think I will launch one. Okay, close to reach the 50. Here we go. I think now you can see the results.
Yes, thank you. So almost half selected D, and then the second most common was B. So let's take a look at those. Okay, so B and D here. So we remember we talked about the anterior border being the anterior edge of the sternocleidomastoid muscle. So this is the sternocleidomastoid muscle. And remember, this is the thyrohyoid muscle and the posterior third. So this is the anterior edge of level 3. So that's why B is almost correct, but not fully correct. And the correct answer is D, which now it's easy way to think of the thumbs up sign. Okay, that's like almost like a thumbs up. That's part of it. So that's the correct answer is D. Why does that matter? I said, well, why do you matter drawing the thumbs up? Because the lymph nodes live around the blood vessels, their jugular vein, but they don't only live posteriorly. Here's a PET scan, and there is a level 3 lymph node, and sometimes they will bulge, and you can have lymph node presentations anteriorly. So that's why you have the thumbs up to make sure you have adequate coverage of the full level 3. Okay, another poll. I know this is a little bit going ahead because I didn't discuss level 4 yet, but let's see where everyone is at, and then in terms of this. So we have a 55-year-old receiving radiotherapy for a tumor in the cervical esophagus. I guess I'm cheating a little bit. I'm going into esophagus, but it's a low head and neck tumor, cervical esophagus, and he is an appropriate candidate for definitive radiation therapy. And what are the primary echelon lymph nodes you would target? A, B, C, or D?
I will launch this one. Let's go. 1 second. 1 second. Okay. Yeah, we are close to the 50% of of people. I will wait for a little bit. Okay, I will launch now. And
all right, thank you.
here are the results.
So majority said B, and then next second highest was C. So, this one, of course, can always be under debate. When we talk about primary echelon lymph nodes, the primary echelon is C, levels 4A and 4B. But I will acknowledge that it is necessary to individualize treatment for each clinical situation. And if someone had lymph node positive disease, you would easily consider including level 3. But level 4A, 4B is the first echelon lymph node drainage for cervical esophagus. So let's go now into level 4. So level 4, is split between level 4A and level 4B. Now, why is that? So when they look at a level 4A surgical lymph node dissection, they don't go all the way down to the manubrium. Okay, so there is an arbitrary border caudally in the inferior aspect that splits 4A and 4B. Now 4A receives, again, efferent lymphatics from 3 and 5, retropharyngeal, pretracheal, and recurrent laryngeal lymphatics. You would consider it definitely as primary echelon lymph node drainage sites for hypopharynx, larynx, thyroid, cervical esophagus, and rarely, but sometimes even anterior oral cavity. Now, why is 4A important? This is an old paper from 1997 from the University of Florida, but this is what they reported on is the incidence of skip metastases in oral tongue cancer. And that's where it's important when you're considering, I'm sorry, not University of Florida, MD Anderson, but they found 16% incidence of skip metastases, and the disease can be only found in level 3 and level 4, skipping level 2 and 1B in oral tongue. And that's why a supraomohyoid neck dissection, which is only of levels 1 to 3, is considered inadequate, and level 4 needs to be dissected as well. So let's review the borders. The superior border for level 4A is the caudal edge of the cricoid cartilage. Inferiorly is 2 cm cranial to the sternal manubrium. This is that arbitrary caudal border where they said, well, most neck dissections end around here. So they said 2 cm cranial to sternal manubrium. And one thing I want to really acknowledge is these borders and these sites are all guidelines, right? We know all humans, we come in different sizes and shapes. And sometimes there's always going to be some interpretations that need to be made for each individual case, but these are guidelines. So anterior is the anterior edge of the sternocleidomastoid muscle in the cranial aspect, and then the body of the SCM when we go lower down and level 4A. Posteriorly is the posterior edge of the sternocleidomastoid cranially, and then the scalenus muscle caudally. Laterally is the deep surface of the sternocleidomastoid and the cranial aspect, and then lower down the lateral edge of the sternocleidomastoid muscle. Medially is kind of a conglomeration of structures. The medial edge of the common carotid artery. You have to be mindful of the thyroid gland, and then the scalenus muscle. And then lower down, you can use in the inferior aspect, the medial edge of the sternocleidomastoid muscle. So let's review those, this slice. So here, what I want to point this out is there's the esophagus here, and it's bulging. Once you see the bulge, you know you are below the cricoid cartilage. So you know you've passed from level 3 into level 4. Anterior border, here's the anterior aspect of the sternocleidomastoid muscle. You can continue with your thumbs up here, right? Laterally is the medial edge of the sternocleidomastoid muscle here. Posteriorly, the sternocleidomastoid muscle. Here we have the scalenus muscle, and then we have the carotid, and then you have the thyroid gland. So here's just an example. Let's go to now level 4B, the medial supraclavicular lymph nodes. Now, these receive lymphatics from levels 4A and 5C, and also include pretracheal and recurrent laryngeal. Again, when are you considering 4B lymph node coverage? For hypopharyngeal tumors, esophagus, larynx, trachea, and thyroid gland. What are its borders? Now, the superior border is a continuation of the inferior border of 4A, which is 2 cm cranial to sternal manubrium. Cranial edge of the sternal manubrium is the inferior border. Anteriorly is the deep surface of the sternocleidomastoid muscle and the deep aspect of the clavicle. Posteriorly, again, is the scalenus muscle, the lung. On the right side, the brachiocephalic vein, brachiocephalic trunk, and the common carotid artery and the subclavian artery on the left side. Lateral is the lateral edge of the scalenus muscle, and medially the lateral border of level 6, the pretracheal component, and the medial edge of the common carotid artery. I'm going to fully acknowledge that level 4B, it all depends on patient positioning, how the clavicles sit. And also here, with patients, different sizes and lengths of their neck, you have a lot of variation how level 4B is drawn, okay? So I know this is trying to provide some guidelines, but there can be a lot of variability. So let's mark out those borders. So now you'll notice the sternocleidomastoid muscle, which was a long, elongated muscle higher up in the neck, starts moving anteriorly, and it's right here. The subclavian artery vein here. Scalenus muscle is stretching out here. We have the medial edge of the sternocleidomastoid muscle here, common carotid artery. You have the thyroid gland here. So this is kind of how it can look. So it's just to be mindful of the thyroid gland to make sure you're covering the space behind the sternocleidomastoid muscle and covering the carotid artery. Posteriorly here, following just above the blood vessels, the major trunks, whether it's the brachiocephalic or subclavian. And then laterally, this is where you can have a lot of variability because there's some room for interpretation here. Some people may stop right here, some may go a little further, and there's some variability there. This drawing here on both sides, just an example here. Now, there can be special circumstances, which I wanted to touch on. But before we get into special circumstances, maybe this is a good time to pause and address any questions that have come up for kind of standard, anatomically intact, level 3, level 4, A, B, targetability.
We have a question about if you're going to treat level 4A, do you need to use a bolus or not?
You know, that's an excellent question. That, again, depends on the patient's habitus. Sometimes we have very thin patients, and if you feel that it is quite superficial, you may use a bolus. I frequently will consider using bolus in the surgically dissected neck, and that's where I'm going to touch on it. For neck dissection, there is a change in the lateral border. And when we have a neck dissection, you were going to come more superficially, and you may be including either the medial half of the sternocleidomastoid muscle or the entire sternocleidomastoid muscle. And then that definitely would consider bolus, but that's a great question.
Thank you, Dr. Patel. Also, another question. I know some people in the US treat the superior part of the head with IMRT and they use the lower part with electron. Do you have any comments about that? Do you use in that way or just perform IMRT for the whole neck?
We go IMRT the whole neck. Again, I think there was some institutions doing that split treatment trying to really reduce dose to the larynx and the midline structures with the block. But that's largely become historical. And all of our sites here at Mayo Clinic do whole neck IMRT.
Okay. And then I have one more question here, and is when you treat level 4, so sometimes you have to go so deep, close to the lung, to the superior part of the lung. So do you use any special, have any special consideration for that?
No, that's a great question. And that comes down to now the variation in anatomy that we can see. Sometimes to cover level 4 entirely, we don't need to go all the way to the manubrium. Sometimes we can stop short because we end up going into the superior mediastinum. And I only go into the superior mediastinum if I'm concerned about a very low tumor like a esophageal tumor or a hypopharyngeal tumor that has, or a thyroid tumor that has disease extension inferiorly. But that's a good question. But I don't draw into the lung. I use those blood vessels as a border. But yes, going in the most inferior aspect, sometimes you're drawing close to the lung, but I never draw into the lung. One thing I do notice, and it's expected, is that you're going to have some apical lung scarring when you treat level 4, particularly level 4B, long-term on follow-up. Just is unavoidable.
Okay. Thank you, Dr. Patel. I think we don't have more questions for now.
Okay, so let's go into the special circumstances. The questions were great because they kind of bring up some of these issues. So for neck dissection, this is an example. So here we have kind of the more traditional lymph node volume here. Oh, see, I'm going to criticize myself here. I would go a little bit more anterior here. But this is an intact neck. But let's say here there's a wire on this neck dissection scar. And the neck is dissected and has lymph node positive disease. Many people would cover the entire sternocleidomastoid muscle in the lateral border because this has now been surgically disrupted. You'll notice some people would vary. They said if there were well encapsulated small lymph nodes, maybe I'm just covering the medial half of the sternocleidomastoid muscle. Medial half meaning just this half right here. But if I have extranodal extension or significant amount of bulk of disease, then I'm concerned about having microscopic disease infiltrating the sternocleidomastoid muscle, you treat the entire muscle. What is the risk of this? The main one is going to be lymphedema. After neck dissection and treating the entire sternocleidomastoid muscle, you're going to have more superficial dose to the neck, and you're going to have a little more lymphedema. The next thing I wanted to illustrate touches on the question about the lung. Well, yes, inferiorly, everyone's different, and also the positioning is different. Everyone has different sized necks. They cannot bring their shoulders down all the way. And so some folks, you're going to end up drawing close to the lung. For example, here on this lower left case. And it's just this I just showed this as illustrative of how you could be drawing the same level, but it's going to look different on each patient. Then there's some adjustment and judgment call. And even if you ask 10 experts to draw this, all 10 can be different, particularly for level 4B. But again, level 4B, the medial supraclavicular nodes are really only for those specific instances I mentioned. And frequently, for many cases, for oropharyngeal, larynx, oral cavity, just covering down to level 4A is sufficient. So now we're going to move into a little bit of the organs at risk. So I wanted to just start with a little poll here. And let's assume that you combine the supraglottic and glottic larynx into one organ at risk called larynx. Where does the larynx contour start cranially? At the inferior edge of the hyoid bone? At the superior edge of the hyoid bone? Midway through the hyoid bone? Or as long as you contour the epiglottics of the OAR2, any of the above are equivalent. And this is just referencing our guidelines.
Okay, I will start. Okay, now people are a little bit more shy, only 35%, waiting for more. Okay. Okay, 50%. Let's go and show. There are the results.
Okay, no, thank you. So yeah, so the most popular answer is B, which is correct. Answer B. So it's easy to remember. A good larynx is start at the top edge of the hyoid bone and then work your way down. And it's also important to note that you can draw the epiglottis separately if you need to, but that choice D is incorrect, which, choice D is as long as any of the above are equivalent. You want to draw the larynx always in its entirety. So when you're doing your treatment planning, you want to minimize the risk of dysphagia and aspiration risk. So I want to highlight this reference. This reference is very important because this has consensus head and neck organ at risk guidelines and has a supplement, including an atlas. Okay, there's a PDF atlas in there. And so what I want to highlight is when we're drawing levels 3, 4A, 4B, the midline structures, the ones that become more of interest and concern are the ones now leading down into our aerodigestive tract. So starting from the pharyngeal constrictor muscles, supraglottic larynx and glottic larynx, cricopharyngeal inlet, cervical esophagus, and then brachial plexus. And these, what I would like to say is, it's important to draw these so that you can help minimize dysphagia and aspiration risk. And particularly the brachial plexus, you can consider sometimes avoiding hot spots to avoid any neurologic detriment. But these are the important ones to consider drawing and looking at the atlas. And the borders are listed here. I'm not going to read every single border, but I wanted to provide that reference, which is important to look at. And I can spend some time reviewing this when we go to the pro-no cases. So let's look at larynx. That's a common one we like to draw, and we just mentioned. How should you contour the larynx? We have A, include the bone and cartilage. We have B, draw halfway through the bone and cartilage. C, exclude the bone and cartilage. And D, there are no guidelines.
Thank you. Bueno, tenemos esta siguiente pregunta para el contorneo de la laringe, donde, no, perdón, es cómo debemos contornear la laringe. Vamos a tener 4 opciones y esperamos que puedan seleccionar si es la A, donde incluyen el hueso y el cartílago, la B, como mitad entre el hueso y el cartílago, la C, donde excluyen el hueso y el cartílago, o la D, donde no hay un consenso. Tenemos el...
It looks like a race. It looks like I'm watching an Olympics race between A and C.
Yeah, it's like that. Also, we are still waiting for more people because people is shy. We're waiting for a little bit more participants. Okay, let's go. These are the results.
Okay. So exclude the bone and cartilage. Correct. C gets the gold medal. So including the bones and cartilage is a common mistake, and that's an issue. You don't need to contour them, and they're outside the borders of the larynx. And again, there's a reference here. You're going to have access to the slides and these references. And these are important references to keep in your file with the atlas, just because it takes a lot of practice when you're drawing the organs at risk. Certain ones like larynx are very straightforward, but pharyngeal constrictor muscles or brachial plexus, this takes time and practice. That's why I wanted to just bring out, they also have another supplement on the brachial plexus. I'm going to show you my technique for drawing the brachial plexus on Prono, okay? But there is this step-by-step process you can follow, but I'll show you my approach as well. But again, this is another one that also has a atlas and a step-by-step contouring guide on the brachial plexus. One thing I want to be very clear is that I don't really, if I have disease, gross disease next to the brachial plexus, I don't sacrifice coverage. But I am ensuring that I'm not placing hot spots right in the brachial plexus.
Dr. Patel, are you
Huh?
contouring the brachial plexus for every head and neck patients you treat level 3 and 4?
I do as a routine practice, but I know that takes a lot of time. It's more important if you have gross disease in level 3 and 4. If you're treating level 3, 4 electively, it's probably less important. But if you're treating it with gross disease, that's where it becomes more of a important consideration.
Thank you, Dr. Patel.
Yeah, so at least in the presentation part, this concludes what I'm describing in terms of the borders. So levels 3, 4A, 4B, they all are a continuation, right, of the jugular chain of lymph nodes. Again, I really want to emphasize the borders are guidelines, but humans are unique and different, and we always have to take into their anatomy into account, also their prior treatments like surgery. And there's also disease considerations like extranodal extension and such when you're contouring these diseases. Also, do not compromise target contours to avoid overlap with OARs. That's important, right? Always want to treat the disease first and limit toxicity as well as you can. But you do not want to harm your local control just to avoid toxicity. So I'm going to also leave my email address here, okay? We're going to keep talking, but I just wanted to give you my email address. If questions come up on levels 3, 4A, 4B, you're welcome to reach out to me, okay? Or about the organs at risk. So now let me pull up, let's see.
Ahora vamos a discutir y conversar algunos casos que el Dr. Patel ha seleccionado y en una plataforma de Pronom, gracias al auspicio de la Alianza con Electe Rayos contra el Cáncer. So, Dr. Patel,
Yeah,
please.
I really appreciate everyone participating and giving this a try. I know it's hard, but I appreciate the participants trying. So let's review this case, okay? So this case is one where it was a 24-year-old female with oral tongue cancer. She had surgery, and there was a question also of lymph node positivity in level 1. Oh, no, I'm sorry, level 2A and 3. So I'm just going down to the plan where the instructions was to provide a high-risk dose to the left tongue surgical bed, intermediate risk target volume, CTV, to left level 2A3, where the gross nodes were sitting, and then the standard risk elective dose to bilateral necks. So I highlighted some structures here. So let's first review the larynx, okay? Since yours is fresh. So we talked about the superior edge, right, of the body of the hyoid. So this is where top of the hyoid would be right here. So we put maybe 1-2 slices a little higher, but that's okay. Now here, remember we're drawing within the cartilage, right? We don't include the hyoid, so we would be including this within. I think I can. I don't know if I can. No, it looks like maybe I can't edit, but so now we're right here again, thyroid cartilage, right? So I would draw my larynx like this inside the thyroid cartilage. We talked about this is a common issue that comes up, that people will include the thyroid cartilage, but you want to draw in within it for the larynx. Okay. Is that clear, Claro?
Yes, I think it's clear. Sorry, I was trying to draw the larynx just to show the difference.
Yeah, I don't think I have the ability to edit here.
Now, I think you can put in the Zoom and then
Zoom,
in
the
the
Zoom,
Zoom
annotate.
use the draw in the Zoom.
Yes, yes.
Yes, yeah, that's it.
Oh yeah, wow, everyone's participating. Excellent. That's great. So now let's go. Thank you, everyone. Yeah, this is great. We have a lot of people participating.
Thank you to everyone. I will delete. Voy a borrar ahora un momento. Les pido que por favor, gracias a todos los participantes.
Yes. So that's great. Another thing is now we talked about, let's go back to these notes. PTV, they wanted the 5,700 centigrade dose volume to cover levels 2A and 3, right? Which is the orange CTV. So I know this is not, you already had level 2, right? The lecture? Yeah, you had level 2. So level
Yes,
2,
Dr. Patel, we already have that.
yep. So level 2, we remember starts at the caudal edge of the transverse process of C1, right? Like right here. So this orange volume should be starting here. And it would be, we wouldn't be drawing the peripharyngeal space, but it would be something like this. It's a common mistake also when you're drawing up, and I know I'm not supposed to talk about level 2, but also just mention
Thank you.
that
Go ahead. We are learning.
is to go into the paravertebral muscles higher up, right? But the sternocleidomastoid muscle is out here left. Okay, just wanted to kind of bring that up. And then there's a parotid gland sits there too.
Voy a pedirles, sorry, doctor, voy a pedirles a todos que, por favor, no, les agradezco que quieran dibujarlo, solo cuando sea como el momento les voy a decir a todos para que todos lo intentemos dibujar, porque si no nos vamos a llenar de dibujos y no va a ser posible que el doctor Patel pueda mostrarnos los de él, pero por supuesto que la idea es que todos participemos. Solo voy a borrarlos por ahora todos y esperemos que sea como el momento. Dr. Patel, I just told everyone that when you tell us, everyone is going to try to draw, but just when you ask for that.
No, okay, yeah, that's fine. I'm excited. We want to make this interactive, so that's great. So how about here? Can everyone draw level 2 for me here?
Thank you.
And so this is common. You get all experts, and
Yes.
everyone will draw something different. That's what happens. So yeah. So let's erase, and I can draw.
Yes. Por favor,
Oh, I think someone was having fun, or someone went out last night.
Yes, I think so.
Okay, so let's see again. You're drawing the blood vessels right here.
Por favor,
right?
les pido, solamente vamos a dejar, ya el doctor Patel está dibujando.
Right. So just illustrating that. So now let's go down to lower down to level 3, right? So now level 3, we talked about the caudal border, right? So they started drawing level 3 a little high here, but again, it goes lower down right here. Bottom of the hyoid bone, right? So now we have level 3. But we know we talked about thumbs up sign, right? So here, let's see, Dr. Gonzalez-Mota, can we erase these?
Yes,
And then
yes, of
I
course.
will,
Just right now.
okay. So we see here, we already, 1B was already covered, but we talked about, remember the thumbs up sign, right? So we talked about the posterior third. I know this does not have contrast, but this is the posterior third of the thyrohyoid muscle and the anterior edge of the sternocleidomastoid muscle, right? So we're going to have like a thumbs up sign, medial edge of the carotid here, and we're going to go to the posterior edge of the sternocleidoid mastoid muscle. Now, if this was surgically not touched, right, undissected neck, I would stick to the medial aspect of the sternocleidomastoid muscle and draw, right? But this patient had a neck dissection. Yes, left lymphadenectomy. So then that's where you want to consider covering the sternocleidomastoid muscle like this. Does that make sense?
Yes.
So that's just a feedback here. Another thing going lower down is just when you're drawing, let's see, can we erase these now?
Yes. Just right now.
Okay. So medial border, this is another common issue, is the thyroid gland, right? Without contrast, you can still see the thyroid clearly here, right? So you don't want your contour to go into the thyroid. We know it's going to receive incidental radiation dose, but our target volume is not the thyroid here. So we should stay lateral to the thyroid here. And then we want to include a thumbs up sign here, right? Or thumbs up, and then bring it here. And also, when you're drawing level 3, that orange volume, we should go all the way down to the bottom of the cricoid, right? We wanted to cover levels 2 and 3. Bottom of the cricoid, right? This is the cricoid cartilage.
Dr. Patel, we have a question. Do you always include the externocleidomastoid muscle after surgery or only when you have extra lymph node positive compromise?
Excellent question. At minimum, when the neck is dissected, I cover the medial half of the sternocleidoid muscle. So I do cover at least part of the sternocleidomastoid muscle that's been surgically dissected. This is kind of my own little pearl, is I cover the medial half, just like here. You see how it's covered, just the medial half. But
Right.
if I'm worried about invasion of the sternocleidoid muscle, the extra nodal extension, I cover the whole muscle.
Okay.
Okay. But it's not wrong to always cover the whole muscle if you want to. But I just wanted to kind of illustrate that we want to be mindful of the thyroid gland here and also be consistent. You see how here someone is coming up more appropriately anteriorly here, but then one slice up is like this. So that's the difference when you're drawing, from a 2D and 3D era to IMRT, is it does take some time to draw these. Sometimes planning software will have interpolation option. So you can draw once every 2 slices or once every 3 slices and interpolate and review and make edits to save a little bit of time. But that's something that you have to be mindful of, is just being consistent here. And what I was illustrating here is the inferior border of level 3. As you're going down, you have the cricoid cartilage, right? Now, do you see the bulge of the esophagus right here? So the cricoid cartilage is a circle. And as soon as it transitions, and you see the bulge of the esophagus, the cricoid is gone. And now you're moving into level 4A. Okay? So this is one thing that the transition here. Same thing for the transition for the hyoid. People say, well, hyoid is here, right? No, we're talking about the body of the hyoid, right? So this is the body of the hyoid right here. And that's where we want to use the bottom edge of it to start the transition of level 3. Now let's go into this case for level 4. Again, we want to avoid the thyroid gland. Now, we don't need to draw the muscle here, right? So like if I was to draw here, level 4A, anterior border here, this would be level 4A, right? And this will be 5. I think next week you'll have 5. I think my colleague, Dr. McGee, will be talking about 5, but I won't talk about 5 right now, but this is level 4A, okay? Just to kind of give you a sense.
Okay.
So let me bring up another case here. All right. So this one was a unknown primary case and has gross disease and bilateral necks. And I think in this case, again, I wanted to review level 3 borders. And here, when we're looking at level 3, the anterior border, again, I'm going to just talk about the thumbs up, right? We want to go up anteriorly here to the anterior border of the sternocleidoid mastoid muscle and a posterior third of the thyroid muscle, because some lymph nodes can sit here. And then posteriorly, want to go right to the posterior edge of the sternocleidomastoid muscle, which is close here. But here, do you see the gross disease is here, but the sternocleidomastoid muscle is here. So this is still part of level 3, right here. And this also is a question here, like this is a lymph node where you're seeing the question of maybe is there invasion of the sternocleidomastoid muscle? It's not clear, but maybe, or there's some concern of extranodal extension. This is where you can cover and treat the sternocleidomastoid muscle and include that in your CTV. And then here we have contrast, so that's a little bit more straightforward to see. Now, we talked about the low neck, right? Like it's a little bit not clear, right? What do we draw when we have the low neck here? So again, here, there was a question about the lung, right? Down here, like what do we do here? So again, this is sternocleidomastoid muscle, right? We want to stay anterior to the blood vessels, right? Like this. So you don't need to include the blood vessels, on this side of the subclavian artery and vein in your CTV. So you don't have to have your target CTV right up against the lung. Same thing on this side.
Dr. Patel, someone is asking, how much margin should we use from GTV node?
Margin for gross disease. So have you had any discussion, I don't know, in the lectures about 5+5? So the 5 mm margin expansion and gross disease.
You have talked a little bit, but maybe it would be better if you review, because not all who are in this session.
Okay. Yes. No, very good. So a common practice is what is called 5+5. So what you do there is, let's go to some gross disease here. Okay, right here. So your GTV, let's see, we have there's your GTV lymph node, right? And you expand by 5 mm. That is your CTV 70, your high dose. Okay. Now that's your first 5+5, right? So the second 5 is your CTV intermediate, which is this orange volume. And you would add another 5 millimeters to ensure you at least cover here. Here we're covering the whole lymph node level, so that's okay. But here, you could add another 5 millimeters right into the sternocleidomastoid muscle to have another additional margin on your gross disease. And that's the concept of the 5+5, is that you're adding a 5 millimeter CTV margin to ensure that you cover all of the gross disease. But one thing that's important is that you're doing anatomic cropping. What does that mean? So here, let's go to this gross disease right here. Anatomic cropping means is that you're taking it out of the air or out of any bone that you're not concerned about. If you're worried about epiglottis invasion here, sure, include it. But if you're not, like here, I would take it out of the air. So here, you want 5 millimeter margin here and here, but you don't need the 5 millimeter margin in the air. That's your CTV 70 here, like this, which is correct. And then you'd add another 5 millimeters for your CTV intermediate, which then would be here, like this. So it's a good question. So that's something that I just wanted to kind of bring up is in the primary site, the 5+5 has anatomic cropping, but in the neck, you add the 5 millimeter margin on your lymph node, but usually you're covering the whole lymph node level for your intermediate risk volume. Does that make sense?
Yes, that makes a lot of sense.
Okay. So in this case, I brought this case up to just talk about, which was nice here is, let me just turn all the volumes off here, is brachial plexus. So we have the brachial plexus here drawn, someone has drawn it here. And we know it's a C5 through T1 nerve roots, right? So I'm going to show you what I do for the brachial plexus, okay? So I guess I'm going to use this. So, if you look beyond the subclavian artery, usually you will see here, do you see this? These nerve roots here. So what I do is I like to start inferiorly, find the nerve roots, and then go back up. So I go backwards. I don't go C5 through T1. I go from the bottom of the brachial plexus and go back up. So you see the nerve roots here, you can contour, and I go up. I'm going to keep going up. Now, do you see this right here? That's like the T1 coming down right here into here. And then what I do is I draw that same space right here between the scalenus muscle and here, just like here. And we keep going up. Right, we have T1. Then you have the C8. You see the C8 nerve root here. And you go up. These go back up. And you have the C7, C6, and C5. So I thought this was actually a nice attempt at drawing the brachial plexus. I mean, just a little adjustment here in T1, but whoever drew this did a pretty good job. Let's look at the right brachial plexus. The same thing here. I like to go a little bit lower down, follow. You have the T1, and then 8, 7, 6, and 5. See, easy peasy. Then you have brachial plexus. You can actually draw it faster than you think. And then if you look at the brachial plexus, usually you can do also another check on your coronal, right? To see if you have the right nerve root levels. Again, it's something that takes practice and that takes time. And that's something that I really recommend consider drawing it when you do have level, low jugular level 3, 4A, 4B lymph nodes involved, and you want to really maybe consider reducing some hot spots. But I don't ever underdose my gross disease. I still treat it to 70 gray. And I don't underdose to keep the brachial plexus under 66 gray, for example. Ideally, I like to keep the point dose to the brachial plexus less than 66 gray if possible. But if not possible, at least I'd like to keep any hot spots outside of the brachial plexus. Let's bring up, I think we have one more case I wanted to show here. Let's see. All right, let's see. Dr. Gonzalez-Mota, can we just erase this? I think we just have some.
Yes, of course.
Oh, no worries. Okay. So now we have a 63-year-old with a P16 positive palatine tonsil cancer that had an intraoperative biopsy by tonsillectomy and also has tumor that invades, let's see, a left cervical lymph node dissection with tumor rupture. Okay. And then has a repeat CT scan with residual disease being found. This patient has HPV-related disease. And you're planning an IMRT plan here to treat the palatine tonsil cancer to the oropharynx and left cervical surgical bed. Or option is drawing bilateral disease. Now, this is example, if you know that the tumor was ruptured, then you have concerns of disease in the fat spaces, and this is where you would consider maybe including the sternocleidomastoid muscle and being very generous with your lymph node target volumes on the left neck. Now, when we look at this neck, do you want to maybe, do we want to redraw level 2 here? Maybe everyone wants to try redrawing level 2 here on the left.
Of course. Bueno, ahora todos vamos a utilizar el lápiz y vamos a hacer nuevamente el nivel 2. Entonces, adelante, todos bienvenidos a participar con el lápiz en la pizarra. Para los que de pronto no saben dónde está, en la parte izquierda de sus pantallas hay un pequeño lápiz, dice anotar. Pueden seleccionarlo y empezar. Bienvenidos todos a participar. Okay, a lot of participants, Dr. Patel.
Okay, yeah, a lot of nice ones. Looks good.
Some of them are also doing the contralateral.
Yes, very nice. Looks good. So thank you everyone. This is good. So what if you want to erase, then I can just show how I would.
Okay.
Yeah.
Thank you, Dr. Patel.
Yes. So see, when people are drawing, they're trying to draw maybe 1B here if they needed to, right here, because it's a submandibular gland. But above, it's important to know this is the medial pterygoid muscle. And here, you're probably including part of the parapharyngeal space because this is a tonsil tumor. But down here, when I said, let's draw level 2, and I think most of you are very good. Like when we're drawing level 2, this is my main consideration is here, right? I'm including the sternocleidomastoid muscle here because there was a rupture here, but like here, right? So excellent. So I hope this was useful for everyone. I think this now concludes my feedback session for everyone. If there were any outstanding questions or concerns, I'm happy to answer or show if someone has anything they'd like to bring up.
Muchas gracias a todos. Okay. I think I will ask you something, Dr. Patel, when you are doing your contours, you used to contour each level, or you just do as a whole?
Yes. So, I think in the beginning, it's nice to practice and draw each level, but no, I draw as a whole. So I draw based on the risk level, high risk, intermediate risk, low risk. So it depends. Sometimes I may have, most of the time I have two dose levels, high risk and low risk. Sometimes I add intermediate risk, but then I just draw those risk levels.
Okay. And okay, what do you think about the automatic organ at risk contouring programs that some of the software are coming
Yeah,
with?
that's going to help, right? That's going to help. I think I've evaluated some of the software and the results are very mixed. Sometimes it can be pretty nice and helpful, but majority of the time it requires editing. It's not automatic and you leave alone. It requires editing
I agree with you.
because, yeah,
I have tried some of them, and most of the time you also need to be careful because for a very regular patient, maybe it goes good, but then, as you said, every patient is different and the anatomy could be changed between one or the other. And
yeah, oh, go ahead, please.
no, just no, please finish. I have last question. Just go ahead, please.
Yeah, no, I was just saying is that a lot of the softwares continue to improve with more training and they're getting better. But I think the future is going to be automation, but it's not 100% there yet. And it's better to know and practice yourself first than rely just on the machine.
Dr. Patel, one more question. What is the margin that you use from your PTV to skin? How much millimeters do you use when you crop?
Okay. Yeah. So our dosimetrists are cropping at least 2 millimeters from the skin. Okay. Now it depends. Most of the time they like to do 3 millimeters if they can. Now, this depends on the patient. But if it's shallower, 2 millimeters or less, because you're concerned about target volume coverage, then you should add bolus. Then you need to add bolus.
Okay.
But ideally, if we're going to try to crop from 3 millimeters if we can. A lot of Americans here are big. So there's a lot more fat in the neck. Okay. So we can crop and okay. But if someone's very thin, you don't have the luxury of cropping 3 millimeters, then sometimes you may have to consider 5 millimeters bolus to make sure you have enough superficial dose.
What material do you use for bolus?
So good question. We're using just the super flap.
Super flat.
Super flap.
Okay.
Yeah, I think that's just the kind of the name. It's a super flat bolus. A lot of times now, new technologies like 3D printing are being used.
Right.
So sometimes we can 3D print the bolus, but we're using typical, just really standard for us as a super flat bolus.
Okay. And sorry, just one last question. Do you use
Sure.
to resimulate your patients? How often do you do or not? Do you use AERT daily or not?
Yes, excellent question. So yes, we use daily IGRT, so using cone beam CT daily to assess the patient. If patient is losing weight or I have some concerns on cone beam CT, then I will resimulate the patient and make a new mask. For definitive radiation therapy, I kind of think around week 4 sometimes is a good time if I'm seeing a good tumor response on the cone beam CT or on clinical examination. I may resimulate the patient to readapt the tumor volumes.